Um, as long as most people are in, I don't think I'm going to wait for everybody to come in. This last session was entitled Putting It All Together, and you will get multiple perspectives from medical specialists. The first speaker is Dr. Yogesh Kalkonde. He currently works with the Society for Education, Education Action and Research in Community Health at Gadchiroli, also known as, by the founders' names, Dr. Bang and his wife, who actually set it up. But Yogesh has more to him than just that. He was actually originally trained as an immunologist, then became a neurologist, and now he's into community medicine. Yogesh.
Thank you so much. I think we are transitioning from myth loka to mrityu loka. We are trying to assuage the sufferings in mrityu loka with discussions on myth loka, so coming back to reality. And so I'm going to discuss, but before I do that, I would like to thank the organizers for this invitation, Dr. Gursani and Dr. Simha. And so what I'm going to do is, I'm going to share with you what I have learned over the last 8-9 years regarding changing faces of death in India as health and economics collide. And 10 years ago, I would not have known anything about this topic. So I'm going to share this through a journey as to how I learned. So I'll use a story format to tell this. So in 2011, I moved from Baylor College of Medicine to work in Gadchiroli. So it was just crossing half of the world back. And this is the place that I work, about 800 kilometers from here. And Gadchiroli is one of the most underdeveloped districts of India, has a population of about 10 lakh. About 40% of the population is tribal, 89% is rural population, and physician to population ratio is about 1:5,000, as against 1:1,300 in the rest of the India. So this was a big transition. So I used to work at Texas Medical Center, and from there, I suddenly transitioned to these areas. And I had also changed my role. I mean, as a physician, we are all treating one patient at a time, but as a public health physician, I have to take care of a larger population. So here, we work in 86 villages with a total population of about 100,000. So change in perspective. So how do you figure things out? And one of the questions that I had was, what could be the health priorities of rural tribal Gadchiroli? So I had no clue what their rural priorities were, and we're trying to figure out how to measure this. So you go to villages, this is what we call rural village, and then this is a tribal hamlet. And looking at these, you start making some guesses. So this looks like a malaria, pneumonia, diarrhea, tuberculosis type of phenotype of these villages. But the key question was, what method I used to measure it? And this quote from Simone de Beauvoir came in handy. It says that you don't die from being born, nor for having lived, nor from old age, you die from something. And in public health, if you figure out what people are dying of, it gives you a beautiful construct or a format through which you can figure out what are the health priorities of the communities. The big question was, how do we figure this out? Because in rural areas, not all people are probably dying in the hospitals. The cause of death is not certified, so how do we know? So we used a method called verbal autopsies, and I call it stories that people tell. So they have died, but they leave out some information which you can use to actually help them out. So what are verbal autopsies? I'll tell you, this is a narration in the verbal autopsy. Some of you can read Marathi, but I'll translate it for you. So essentially, this is a guy, 32 years old guy from a tribal village. He was using tobacco for about 12 years and used to eat tobacco for about 10 times a day. At night, he used to sleep with tobacco in his mouth. Gradually, he had a lump in his mouth which started growing. He was taken to the hospital of Surge, was given some treatment, which was not helpful. Then he had progressively more difficulty, having food. So he was taken to the tribal pujaris, the traditional healer, and he tried to do some, care. And gradually, he had fever. His oral intake went down, and he died. So, this guy could have died in the village, and we would not have known what he died of. But this information, although not perfect, gives you a reasonable sense as to, what the cause of death could be. So what we did is we compiled such information, and we analyzed causes of death between the period 2011 to March 2013 using this system. So again, as I said, we gathered this information on every death that occurred in these 86 villages with a population of about 94,000. And this is how the system works. So we have a village health worker who informs us about death. Then we have a trained field supervisor who collects the data using narration and long checklist. I didn't show you the checklist, I just showed you the narration. And then 2 trained physicians independently read this narration and they assign cause of death using ICD-10 code. If they agree, that's fine. If they don't agree, then the diagnoses are swapped and we ask them to reconsider. And if they still continue to disagree, a 3rd senior physician adjudicates cause of death. The data is entered, validated, and analyzed. And then when we looked at this, the causes of death revealed themselves. And what the causes of death were, these were the causes of death. And this just shows the percentage of, by each disease, what % of deaths were because of that disease. And what was revealing was essentially stroke was the leading cause of death. And then the next leading cause of death was tuberculosis. So tuberculosis caused 6% of deaths, stroke caused 14% of death. And this was completely unbelievable. In a rural, underdeveloped region of Gadchiroli, why do you have so many deaths occurring because of stroke? The ischemic heart disease was at 4%. You have the usual suspects of diarrhea about 4.5%, malaria about 4%, perinatal condition nationally also about 6%. So we started looking at why this is happening in Gadchiroli. I just showed you the vistas, and looking at those, it looked like, as I said, it's an infectious disease phenotype. So then these are the diseases grouped together. So you can see that in NCDs or non-communicable diseases have already sort of caused more deaths than the infectious diseases. So this is just the lumping of the previous pie chart. And where have people died? So 93% of people died at home. Is that good or bad is a different question, but 93% people died at home. And so essentially, if you just go by medical certification of cause of death, these deaths are never known to the system. And in India, in 2010, 75% of deaths occurred at home. Only 25% occurred in the hospital. So if you go by hospital deaths, you get a very skewed picture, a very biased picture of causes of death. So for me, it was a myth broken, and this is a great quote from John F. Kennedy: "A great enemy of truth is very often not a lie, deliberate, contrived, and dishonest, but the myth, persistent, persuasive, and unrealistic." So it just shook me up completely. Essentially, I need to start understanding why this is happening. And so when we are looking for explanations, as the human mind always seeks explanations. So the explanation that came was epidemiological transition, and this is a term which is used in public health to explain things. And when we try and understand epidemiological transition, we need to understand population as a person. Like a person goes through various phases, populations also goes through various phases. As person ages, the susceptibility of person to various diseases changes, so too happens to a population. And the guy who put this word, his name is Abdul Umran, and what he did is he looked at what were the causes of death in Britain. And what you see is a fantastic march of change in percentage of cause of death. So you can see that if you look at 17th century London, close to 50% deaths were because of infections and diarrhea. Then a large chunk was because of nutritional issues, maternal and infant. So essentially 70% of deaths were what is called as communicable diseases, maternal and neonatal deaths. And then as the time passed by from 1860 to 1960, the infectious diseases gradually came down, and what you see expansion of is essentially heart disease and vascular diseases. And this is not happening in vacuum. What you see in the background is also in England, you see that the birth rate started falling down, the death rate started coming down, and the population started growing. And another interesting thing that he found was that as the life expectancy of the population increased, again the pattern changed. So if you look at the life expectancy at birth is 40 years, and by the time you reach 72 years of life expectancy, the infectious diseases have come down. And the reason life expectancy is increasing is because if you are tackling these issues well. So this is interesting because if you look at India in 1947, the average life expectancy at birth was 32 years. It's unbelievable. And now we come 2017, life expectancy at birth is 69 years. So it's unprecedented because probably in human history, in a span of 70, 80 years, you have put on extra 32 years of life or more than 35 years of life. So you just added another chunk of life after the ones that you are accustomed to. And then what happened is Abdul Umran also gave stages of development of populations. So he called the first phase as age of pestilence and famine, The second phase he called age of receding pandemics. The third stage is called age of degenerative and man-made diseases, and then age of delayed degenerative diseases. So he says that the populations transition through these phases. And then Dr. Srinath Reddy and Salim Yusuf actually came out with numbers. So they said that maybe in these, if you're in this phase, then the percentage of total deaths because of cardiovascular diseases are going to change. So like when I started working in Gadchiroli, I believed that we are in the age of pestilence and famine, but actually our cardiovascular diseases were 20% of total deaths. So we are already in the age of receding pandemics, and this has already happened in rural India. Most of the rural India, if Gadchiroli is an age of receding pandemics, almost every portion of India is age of receding pandemics or forward. If you're sitting in Bangalore, you are in the age of degenerative and man-made disease, and part of the community could be age of delayed degenerative diseases, where we are actually controlling these diseases well. And what are the risk factors? So in the first two phases, you have infection and nutritional deficiencies as the risk factors. Then in the second phase, hypertension starts creeping up. And then in the fourth phase, you have hypertension, and then you have also obesity and diabetes creeping up. And then I modified this little bit because when you're changing from these phases, you also have healthcare response that is changing. So healthcare response also starts improving. So this is a beautiful way of looking at communities, because communities are not, they are not static, they're constantly changing. So this gives you a nice framework to quickly see what phase the community is in. And then, again, as I said, this is not happening in vacuum. You have to understand the context, the socio-economic context of these changes. So let's look at what has happened to Indian population. In 1960, it was 0.45 billion. Now it is close to 1.35 billion. The economic growth, you can see that there's a very little increase until 1990s, and then we open up to market economy, and then suddenly the GDP starts creeping up. And so you can see that now we are going to be in a violent phase where you will have more NCDs creeping in and suddenly sort of creating a problem for the public health. CO2 emissions are creeping up. Life expectancy at birth, as I said, in 1960 it was 41, and now it is 69. And then the question was, how do we measure epidemiological transition in India? If you want to understand changing patterns of death and disability, you have to measure it. And so what are the causes of death in India? So if you go to 2001, 2003, you can see that in 2001 itself, India has already undergone transition, epidemiological transition. So you can see that the number of deaths because of NCDs or chronic non-communicable diseases outnumbering those because of infections. And you move 10 years forward, you see that the NCD chunk has even increased further. So if you go to developed countries, close to 60 to 65% of all deaths are because of chronic non-communicable diseases. And then other way we measure this is using a metric called DALYs or DALYs. So essentially it's the years of life lost. So if the person dies at the age of 20 and its life expectancy is 70, that person has lost 50 years of potential life. And then years lived with disability. So if someone has back pain and he's living, then his life is penalized because of that pain. So if you combine these two, you get DALYs. So this is the pattern of DALYs that has changed in India from 1990s to 2016. And the red colors are essentially infections. The blue colors are chronic non-communicable diseases. The green colors are essentially injuries or external causes of death. So what you can see is there is a lot of transition. A lot of non-communicable diseases have moved up in the ladder. So now the leading cause of burden of disease is ischemic heart disease followed by COPD. Then you have diarrheal diseases, then lower respiratory infections, then you have strokes, and so on and so forth. The other complexity that you have in India is heterogeneity. So there's significant heterogeneity. So if you look at, the scientists have come out with a demographic transition level, so which is essentially a ratio of DALYs lost due to infectious diseases divided by DALYs lost due to non-communicable diseases. The lower the ratio, that means that you're already transitioned. So the blue color is you have transitioned. So if you look at 1990, Kerala was the only state that had transition level, or it has significant epidemiological transition. And the red color means that you have not really have transition. So you see that middle India, which is not transition. But you come to 2016, most of the area is already blue. And you see that the southern India is really, very high on epidemiological transition, and the northern part. The middle part is still sort of lagging a bit. There's also difference or heterogeneity in terms of causes of death and their patterns. So if you look at causes of death because of ischemic heart disease, then you can see that you have Andhra Pradesh and Tamil Nadu having very high mortality rate because of ischemic heart disease in 2001, but then as you move to 2010 to 13, the rest of the southern states gradually catch up. And then in terms of India, majority of the population lives in rural area, and so you can see that the mortality rate because of ischemic heart disease have already crossed those because those in the urban area. So in ischemic heart disease is going to be a big problem in rural India now. And then if you were talking about death and dying, ischemic heart disease in rural area also becomes a problem. Look at stroke, and stroke deaths, for some strange reason, stroke deaths are concentrated in the eastern and northeastern parts of India. We still completely don't understand this, why this is happening, but there's this distinct belt, so to speak, stroke belt in India that we see. And again, if you classify these states into high burden states and low burden states, you can see that in the high burden states, again, the stroke death rates are higher in rural communities compared to urban communities. And even in states where stroke mortality is going down, in the rural parts of those states, you have higher mortality. And then you look at hospitalization and expenditure, and this data Dr. Gursani provided to me, and very interesting data. This is a perspective from hospital, what we see in the hospital. This is something that we are usually accustomed to, and the public health angle that I provided is not something that we routinely see on a daily basis. So you look at hospitals. So the leading causes of hospitalization or hospital-induced, what you see in the hospital in terms of death is again circulatory system deaths and infections. And you can see that the death because of infection have gone down in the hospitals over a period of 1996 to 2014-15. And the expenditures are gradually creeping up. So across the years, you can see from 1995 to 2014-15, the expenditure on death among inpatient has almost tripled in some cases, or doubled for sure. So coming back to Gadchiroli, life is gradually changing in Gadchiroli. When I moved there about 8 years back, this was a common scene. Now this is gradually being replaced by motorization. And how the death and dying is occurring in Gadchiroli, we have conducted some qualitative studies on stroke, so I'll be giving some quotations from that. So this is what the patient feels about death because of stroke. We are talking about dying voluntarily, and this is a common practice in rural area, to my surprise. What is it for the wife who had husband who has suffered from stroke? This is the reality that you see in terms of dying because of stroke for the wife, and this is for the children. You cannot work is a big thing in rural area. You have to work, you have to produce something, you have to be helpful to the family. So with that, I'll stop my presentation. I would like to acknowledge my team. And I would like to also specially acknowledge Anjana Bai. This is a lady, community health worker. I saw her work in 2007 and made up my mind to move from Houston to Gadchiroli. Thanks.
Thanks. So we are flipping perspectives. And the next speaker is Dr. Sanjay Nagral, who will bring in his perspective of working as a specialist surgeon in a tertiary care hospital. Sanjay.
Thank you, Roop. Thank you, Nagesh, and everybody. the local organizers who not only called me here, but have looked after us so well. And one of the sort of important features of my visit to Bangalore this time has been the 10 to 12 minute walk that I had in the morning in Karunashraya. And for somebody like me, it's really something which is very revealing. By the way, when Roop first contacted me, his first WhatsApp message, I don't know whether he remembers this, where is he? Was, he's just gone out, so was, we need you as a replacement speaker. So I said, that's very rude, but doesn't matter, it's coming from Roop. Then, of course, we debated for some time on what I should be speaking about, and we came after 5, 6 WhatsApp messages, we constructed this complicated title. So please don't get too intimidated by it. That bit I've added with some baggage. So, you'll realize as I move along the talk that it's obviously I wear more than one hat, and therefore there's some additional baggage which also I will share with you. Now, this is very different, of course, from Gadchiroli, what you saw. Not very different from, some of it is not very different from Houston. And, but, these are the 2 hospitals I work. So one of the reasons I put up this slide is not to show you nice pictures, but to put it on the record that I work across this big divide, which very much exists in almost all cities in India. So the top is the private hospital where I work. I spend about 60 to 70% of my time there. By the way, the next to the hospital is that building which is occupied by one family, 3 of them. I cross this bridge 3 times a week to work in a hospital of the Mumbai Municipal Corporation, which is one of its largest peripheral hospitals, and the people we serve is the large number of slum dwellers who occupy that area of the city, and as you know, 50% of Mumbai is slum. So and the reason I put this up is to say that some of the things I'm going to say actually come from both the experiences, and I'm going to try and therefore compare a little. What I plan to do is start with a little bit on the changing nature of healthcare and in its ecosystem as I experience it and see it every day. Talk a little of the perspective of specialist surgery and high-tech medicine. By the way, this is Roop's words. High-tech medicine is his word, but so try and give that perspective. Talk a little about the experience of public hospitals, death and dying in public hospitals, large urban public hospitals. I am a trained transplant surgeon, and therefore actually engaged with the idea of dying from another perspective, which is the whole recognition of brain death and deceased donation. And about 7, 8 years back, I was very active in the whole deceased donor movement in India. Some bit of it is policy making and also advocacy as well as creating public awareness. I also have engaged with the ethics movement for many years, mainly through a journal called Indian Journal of Medical Ethics, and also with a bit with the public people's health movement, which is a very vibrant movement in India. And I think those perspectives also I just like to touch upon. Finally, I hope to give some closing thoughts. Largely so that these disparate elements come together and try and join the dots, because Roop told me that one of the reasons to do this session is to look at how does this whole movement move ahead when it engages with the healthcare system. Okay, so I'm not going to read through every word of every slide, but these I think are the key features of the changing nature of healthcare, at least in the urban, large urban metros, but I think slowly spreading to smaller places. So there's a huge retreat of public medicine. You can see a spectacular rise of private medicine, but which is quite unregulated. So it's not the Western idea of private medicine, which is very regulated. Entry of the corporate for-profit sector, huge entrepreneurial spirit, so huge investments, individual investments, group investments, entry of global capital, and of course the emergence of specialization, including a large number of intensive care units and critical care medicine as a specialization. And there are people sitting here who have led the way in the development of this specialization in India. There's a decline of family practice, but essentially what we see is a massive commodification of healthcare and huge conflicts of interest. And I think this has some relevance to what I will mention and what actually has been discussed even since yesterday, which is the behavior of doctors, hospital policies, because I think essentially we are looking at huge conflicts of interest. So death is also commodified, and there is therefore the ecosystem has a certain interest in keeping people alive and not letting them go. Public medicine is largely being abandoned, except the very poor who of course have no choice. There is the unequal power balance, information asymmetry, which we all know, but which continues. So in spite of all this sort of visual, structural, financial progress, and the information asymmetry is still quite huge. There is increasing expectations from providers. And I think a part of this has been pushed by the providers themselves. So we are creating unrealistic expectations in people by claiming to be world-class, high-tech, etc., etc. People have a limited capacity to pay, including the middle class, and therefore they end up with catastrophic expenses. And finally, this is leading to distress, litigation, and of course, unprecedented levels of violence. And I think one of the big crises of healthcare in India right now is the fact that we are seeing increasing violence against healthcare providers. A little bit about the changes in the hospital ecosystem as I've seen it over the last 2 decades through 2 or 3 decades. So there's now a hospital hierarchy which is changing. So there's to be small nursing homes, middle level community hospitals, many of them are closing down, being taken over, and largely we're seeing the emergence of corporate chains. There is, of course, a bit of growth of insurance, and therefore in hospitals you have stuff like the cashless patient, the credit patient. So these are essentially groups of patients who are somebody else is paying. And all this tells upon behavior, all this tells upon the way they are approached, So that's why I'm just bringing it up. There is, of course, accreditation. And accreditation in India is very interesting, by the way, because, Indian healthcare has produced its own incestuous form of accreditation. They accredit themselves. And when they do that, they come up with all sorts of interesting protocols. And one of the things I now experience in hospitals I work is anything controversial where you don't want to engage, you refer to a nebulous sort of entity far away called NABH, and therefore the discussion stops. So the moment you say NABH, the discussion stops. And finally, something that was referred to yesterday was the fact that it is the medico-legal paradigm that clearly dominates the discourse. So it is not about what is a professional commitment. It is not at all about necessarily the ethical commitment, but what is medico-legal. So constantly, Dr. Mani kept on saying this yesterday, and I think it's very true that people are constantly talking of courts and what the courts will do, etc., and not what is the commonsensical thing to do at that moment. Then, of course, now we have the growth of specialty hospitals, and incidentally, in India, a full hospital must be a good hospital. So hospitalization is encouraged. Hospitals are vacant. People are worried that it's a vacant hospital. Normally, you would expect that, people don't need hospitalization. It's a good thing, but people here are worried. So the narrative is that a full hospital is a good hospital. Hospitalization is encouraged for many reasons. There's a large number of ICU beds now with high charges, sometimes significantly higher charges. But there is a low arbitrary threshold to shift patients from the ward to the ICU. There are no fixed protocols, unlike in most of the world. So a patient is slightly breathless or not looking good, you sort of shift to the ICU because you get a better care, a 1-to-1 nursing or a 1-to-2 nursing, etc. So there's not necessarily always a good scientific reason to either shift a patient into ICU or shift a patient out of ICU, and that's also something that plays into, therefore, some of the problems that we see. Doctors, of course, many of them are a daily wage. So therefore, if you're on a daily wage, long hospitalization, investigations, volumes are actually rewarded by the hospital. So therefore, a patient in the ICU for long connected to multiple lines and ventilator, the kind of patient Dr. Manish showed, actually is a sort of, is a huge conflict of interest because it's good for the doctor and good for the hospital. So I think this is a conflict of interest which is very scary, but we need to recognize. Finally, of course, there is medical tourism, which is growing, and many hospitals position themselves now as hospitals predominantly for medical tourism. So I come to what was supposed to be my focus, which is high-tech surgery or advanced surgery. And as I said, I've trained in transplantation. I do a fair amount of liver pancreatic surgery. So it's relatively complex, relatively advanced. So I think the first thing to put on the table is that we have seen substantial advance and hugely improved success rates in our ability to treat surgical diseases. Even things which we could not treat very well about, say, let's say 15, 20 years back, we are able to treat much better. Now, pancreatic surgery is one example where we are much better at performing it without complications. And we are therefore able to treat conditions which were untreatable recently, including in oncology and oncosurgery. I think results are getting better. The problem, though, is, of course, in India, we are not able to produce good quality long-term data. So therefore, somebody asks a question whether that there's data to show that the outcomes of long-term outcomes of surgery getting better, there would be a paucity of data. Technology and tools have facilitated the growth of many of the specialties. I think there's no question about it. How they are used, whether they are used judiciously, is of course a matter of debate. And finally, of course, we are seeing the advent of transplantation beyond kidney. And I think liver is now becoming reasonably well established. We are slowly moving to heart, and we'll soon see, I think, even the other abdominal organs, lung, etc. So all this is, was partly inevitable. There is a lot of globalization, people getting trained, coming back. But then again, all this is happening on the background of what I just told you in the previous 5 minutes. And therefore, the tensions that are coming about are sort of related to this kind of bit of the background issues which are not in consonance with the way healthcare has developed. A specialist surgeon typically in India today has long training, lot of degrees, therefore has a monopoly by the time he reaches there. So there's a sort of God complex with cardiac surgeons leading the way. Focus on technology, technique, and immediate success very much. There is less attention currently in the culture of Indian surgery to quality of life and long-term outcomes. Long-term outcomes is a big paucity, but even quality of life issues are not really focused on. Complications and death we know are unavoidable in advanced surgery, but usually are like a sudden shock to everybody, partly because there has not been enough pre-operative communication. And the picture is often painted to be much more rosy than what it is. And finally, therefore, when it happens, the response is of panic, of sudden, a sort of feeling of suddenly being let down, which is compounded by escalating costs, because a small little complication can escalate the costs manyfold. And there's often conflicting communication, various types of providers give various types of responses to the family, and it results in a feeling of abandonment. And this is not an uncommon scenario in Indian hospitals, in the specialty, surgical sort of section, but also across the board, especially in specialized care and including in ICUs. And I think it's fertile ground, therefore, for a lot of angst, anger, and disappointment. Therefore, the conundrum of the specialist really is that on one hand, he or she is hugely trained, as I said, has sort of reached a sort of near levels of sort of infallibility image of saving and curing people. But on the other hand, there are poor results, there are deaths, and this is perceived as deficit or a defeat of that person and of that speciality. I think the problem also is that typically the more specialized you are, the more you have to be seen to be doing something active, visibly, to the patient or especially to the family. And withdrawing care, therefore, is not a part of the culture of specialization or specialized care. Finally, something that I tried to refer to yesterday, which is that palliation, pain, other problems that patients are sort of now put into silos, and sometimes there are tendencies to refer to people. So psychiatric references are very common in these hospitals, where somebody is not sleeping well, or sort of, there are hundreds of obvious reasons why they're not sleeping well, but there's a reference given to the psychiatrist who sort of typically comes and writes some 2 or 3 medications, or there's grief counseling. So that's also a problem, that the role of the primary specialist is getting narrower and narrower, and their self-image is also of something that they do not look at themselves addressing the other areas. What about public hospitals? As I said, I spend about 40% to 50% of my time in, I trained for a long time, I worked also for a long time in a large teaching hospital in Mumbai. And I think we need to look at that area also, because very often our conversation, our discourse is about the space you and me inhabit, which is largely, whether as patients or family members or even providers, we inhabit the space of private medicine. So we must look at what is happening even in the other half of our system. So the fact remains that public hospital still is the main facility for the rural and urban poor, a big role in public health. They still offer substantive curative services, especially in acute care, including trauma. And the hospital I work in, our surgical department, we do a lot of trauma work and trauma care. And of course, they are training grounds for undergraduate and postgraduate studies. But this is the general image of public hospitals, and part of it is based on a certain reality. Who's doing that reality is another discussion, but they are underfunded, understaffed, perceived as impersonal and of low quality, including the poor. They look at them as low quality institutions, but they come there because they have no choice. Care is largely seen as a big favor in the public sector. So it's a favor that somebody is doing to somebody who sort of deserves to have that favor. So therefore, death and dying and some of the debates and discussions we have are really not sort of at the level of discussion or discourse in public hospitals at all. It's sort of, death is like a matter of fact without any formal discussion or protocols. Whether that is a good thing or not is again open to discussion. But of course, even in public hospitals, we are seeing lots of questions being asked, a lot of anger, and of course, violence. I've done some writing on this, and I think some of it comes from the fact that people are beginning to realize that they're getting a raw deal, and especially now they have a comparator in the form of private medicine and private hospitals, and they realize that they are getting a raw deal in their encounters with the healthcare system. So on the other hand, we talk about therefore the problems in specific hospitals, but when you sort of push surgery out onto the larger arena, and this is a piece I did for the BMJ along with colleagues from 4 countries in South Asia, looking at surgery in South Asia, we realize that actually the problems are much more outside the hospital. Lack of access to surgical care, completely routine surgical problems are not being handled with the way they should be at the right time. And maybe Yogesh can tell us this, that very often people are not able to reach the hospital in time for even basic abdominal emergencies which can be treated with simple surgery. And I think one of Prabhat Jha's work actually looks at how people are dying in many districts of India because they can't get. So this is actually the larger picture, and just put it up to say that sometimes we get obsessed with our surroundings, but the reality outside is different. Therefore, one of the things that troubles me in this whole discussion on dying and withdrawal of care and the Supreme Court cases and Aruna Shanbag and the judgment is the fact that what we seem to be focusing on is a subset of patients who are largely in the big urban private hospitals. And a lot of discourse takes place around that, because that is probably that is a space we inhabit. And therefore, right when the first Aruna Shanbag case came up, the first time did this piece for the Times of India where I said that there is a economic factor in India, and therefore the discourse has to be very different. And when the due judgment came up, I did this piece for the Indian Express where I essentially I gave an example of a patient who was in the public hospital I work, who had a large part of her intestine removed, and she needed parenteral nutrition, which the rich can afford. It can be given 2 or 3 times a week, and you can survive for long, and she could not. So I described that case and said that when we say right to die, right to withdraw care, what is the context? Who is it is also important. Finally, I just come to that third part of my engagement with this area, and I'm sort of shifting gear rapidly, a bit, maybe a bit jarring for you, but I have to try and get it together at the end. But so this is the Transplantation of Human Organs Act, 1994. This piece of legislation essentially tried to do 2 things together. The first was, it was a response to the trade in kidneys. Therefore, what it does, it bans trading and lays down punishments for any form of commercial transactions in transplantation. But the second was, in the very same law, it also set forward the conditions for recognition of brain death or brainstem death to facilitate deceased donation. And the logic behind the people who did it at that time was that they felt that when you have deceased donation commonly happening, and therefore organs are available through deceased donors, the need for live donor transplantation will go down, and therefore the commerce in organs will go down. So I think that was the sort of connection. But whatever it is, as a result, unfortunately, by this accident, brainstem death has become something that is connected to transplantation. The fact of the matter is that you can have a brainstem dead individual who either is not willing to donate or he's not a right candidate to donate. And therefore, today we are seeing this scenario in India, where on one hand, through Supreme Court judgments, through a lot of work done by people sitting here and the ELICIT group, slowly but surely we are moving towards some form of withdrawal of care in those who are terminally ill. But brain-dead individuals who are dead by our law are still being ventilated if they don't donate organs. So this is a huge problem. I think everybody is waiting for somebody to bell the cat. And I think what we are likely to see in the near future is that the Kerala government is probably taking some lead in this and trying to push this ahead. So this is again the same theme. This is Sunil Shroff writing on the same issue, and he says dead enough to donate but not dead enough to cremate. So I mean, you can donate organs, but the body can't be taken home. And I think this is the dilemma that's been continuing for many decades. Okay, so the final few minutes is about my engagement with the IJME, the Indian Journal of Medical Ethics, through which also I have therefore interacted with this whole area of terminal illness, of palliative care. In fact, some of you were there, Pune 2017, we did one of the national bioethics conferences focusing on this theme. And I think in the IJME, we have been very consistently covering these issues, writing on this issue. My other interest also, but interaction has been with the growing movement in India, which is sort of works on right to health care, public health, people's health movement. And I just borrowed this slide from Sridevi's presentation yesterday. I clicked it sitting there. Because whilst we can make these comparisons between the UK and India, the fact is that many of the countries where we give examples of good palliative care models, good models of end-of-life care, are countries which have a socialized healthcare system. Countries which is a purely public healthcare system, where there is a well-structured referral system where protocols go down the line, and we are far away from that. We are exactly the opposite of that. We are the most unregulated and the most privatized of healthcare systems. So I just thought I'll put this up to say that the move forward towards a better approach to end-of-life care, I think also is going to be indirectly linked to the way our healthcare goes. And therefore, if we want the UK model, we also should look at the UK model of healthcare. So we cannot disconnect it from that. I just put that query on the Kerala model because it keeps on getting mentioned. It was mentioned yesterday. So what is the Kerala model? Why did, sorry? Oh, it's coming next, and I know that. But what is the basis for the Kerala model? And is it just about some individuals somewhere who thought that this is all very important, or is it something more, again, to do with the way healthcare was structured, the other determinants of health? So maybe we'll wait for some time for the next talk to tell us about that. I think finally, a few thoughts I can't say this is advice. I have nobody to give advice, but these are just some thoughts and suggestions as to how do we broaden the discourse. Clearly, mainstream medicine, in my view, is relatively uninterested, ambivalent, has conflicts of interest on this issue. And I don't see this changing in a big way. I mean, we must keep on trying, but I see it as in some ways getting worse. What is happening right now in many aspects of healthcare, as in changes in healthcare, is activism, advocacy, legal interventions. This is coming from groups or individuals who are driven. And I think ELICIT is one such group, but ELICIT has managed to go from individuals to at least getting 3 or 4 organizations on board, which is a big step forward. So I think there is a necessity for multi-sectoral engagement, there's necessity for solidarity. I think finally all of us are actually at one level talking about the same thing, which is to give a better deal to our patients and be a little more humane towards our patients. There is, in the last 5 to 6 years, if some of you have been noticing it and reading in the newspapers, emergence of a very strong patients' rights movement. This has typically come from individuals and families who have perceived excesses in their experience, either they themselves or often their family member who they feel has been wronged, who has died in a hospital, where has been some 20 lakh, 25 lakh kind of bill. So they have joined hands with health rights movements and are actively seeking out judicial and policy interventions. And the state is beginning to respond to them. Therefore, I see this as a model where I think even in this area, possibly the push is going to come partly from enlightened doctors, but I think from individuals who have suffered or who've seen the suffering and therefore are a little more consistent in their passion for doing this work. Okay, so final closing thoughts. The predominant crisis in India is the lack of access to rational and affordable health care and increasing commodification. There's no question about that. I think that is the main crisis. A limited discourse around terminal illness, withholding care, palliative care, though necessary, may make limited gains, and I think the gains have already been made through this group and the work of many of you. On the other hand, the right to universal health care has emerged as a big movement and got attention as a political issue now. I think the government is responding. Ayushman Bharat is, I think, one example of that. But there is a feeling in the political class that health is something that they need to respond to, and therefore it is coming on the agenda. Since a comprehensive view of right to health care includes the right to refuse futile care and access palliative care, actually the two movements are in reality organically linked and therefore are natural allies. And I think therefore it is this combining of these kind of forces which probably may make some substantial gains. Thank you for your attention.
Right. So yes, the elephant in the room is the lack of universal healthcare that we can't go away from. But what we are trying to do is show you as many parts of the elephant as possible and perhaps some of the forest around it. So let me now call on Dr. ANIL PALERI, and he will be speaking about how palliative care has been made possible through voluntary action and through community agency in the part of Kerala that he comes from. Where is Anil? There you are.
Good afternoon, everyone. In the last session, I'm the last man standing between you and the lunch. No, we have some. Okay. And I thank the ELICIT team for this opportunity. And I'll try to explain what this Kerala model or the Kerala experience in palliative care is about. You know, whenever you show a map of India, Kerala comes out in a different color, right? Not just a political map, but also when you show the health indices, it's in a different color. And I'll give you the summary in the beginning, like what was happening in palliative care in Kerala, is that we took palliative care out of the hospitals and put it on the street. So it had two options, either to survive or perish. And in Kerala, it survived and also flourished. So I just give you why this happened and what was our experience with this palliative care in Kerala. Why? Because one big way we could engage the community in providing, in supporting palliative care program, in owning palliative care programs. And I'm just looking at the rationale for getting community involved. You know, in most places in India, palliative care programs actually developed outside the health systems, like NGOs, organization kind of were the champions who developed this program. And why that happened? Because the system, the health system often expresses their helplessness when they see or when they treat someone who cannot be cured. Then often they get sent back to home saying that we cannot do anything now, we have done everything possible, now we can go back and be at home. So it's basically sending a helpless person and a family by a helpless system to a helpless community. So community also doesn't know what to do with this person. So when a person with incurable cancer comes back or incurable illness comes back, a person with stroke comes back, they also at a loss. They don't know what to do. So everybody is helpless here. But we always ask the system about their preparedness in dealing with these things. Like we ask the government, we ask the hospitals, what are you going to do about this problem? But what if we say, we felt that we also should ask the community about their preparedness in dealing with such situation. Because it's their issue also. It's not just the hospital, it's not just a health issue that only the doctors and nurses should answer to. So this was the premises from which it started. And the patients with advanced disease, they require continuous supportive care and till they die. And they also need regular social, psychological, and spiritual support in addition to the medical nursing care. And this care, where should the care should be available? The care should be available as close to the homes as possible, because that's where people are going to be. Not every person will be going to the hospital to die. And often they are not given the option to go to the hospital and die, because the moment they go to the hospital, they do something immediately that solve the crisis and then send back to the homes. So they die at home. So this care should be available as close to the homes as possible. And there should be enough social capital. There is enough social capital. Like social capital, people come together, work together for the betterment of the society. And it is available everywhere, and it can form a safety net, kind of safety net for people to fall back onto when they have an issue. Okay. So just saying that this is the premises, and I just showing a slide showing the varying levels of community involvement in projects, just to see, you know, it can be varying. And in each community, the amount of community involvement participation can vary. And a collective action, co-learning, this is called community development, where the people set the agenda, they lead it, they mobilize the resources they carry out without external facilitation. Or it can be a situation where they cooperate. Local people work together with outsiders to achieve things that are good for them. Or it can be consultation, where local options are asked, but outsiders analyze and decide on the course of action. Okay, sorry. Yeah, I'm not able to see the same. That's what I'm stepping back, sorry. Or it can be compliance with tasks assigned with incentives, outsiders decide agenda and that process, or it can be total involvement, action only by the outsiders, where the option is the token involvement for local people. They may elect representative to the team, but actually not much input or power for these local people. So these are different grades in which community can get involved in this project. Then what happened in Kerala is that the program started in 1993 when we had the first program set up in Calicut. There's an organized NGO, But the first time we noticed something, which is very, very surprising, which came as a surprise to us, that we observed when we observed the different programs that's happening in that area, by that time we had around 20 palliative care programs in 2 districts. One of them were doing extremely well. They're doing extremely well. They are providing all the support. They are doing home care on a daily basis. They have employed a nurse. They're getting a doctor. They're providing all the medicines, and they're providing the other supports also, going beyond the issues of the patient and also supporting the family. And when we observed the surveys, we found that unlike the other services, it did not have a professional as a lead. That was something surprising, because all of the programs was either run by a doctor or by a team of doctors, and this program was purely run by the local people, volunteers, and they hired doctors and nurses to support them. That was something revealing for us. So when we understood this mechanism, we tried to kind of change all the existing clinics into that mode, and also the new services that came up in that region were kind of modeled on this the finding that we had. And that's how the concept of neighborhood network and palliative care came. It's an effort to overcome the limitations of biomedical or professionally led model of our healthcare system. Well, when I say biomedical model, I mean that you find the doctors and nurses are responsible for your health. Like, you don't do anything about it, but you just go to hospital and get treated and get cured and go back. You don't know anything about it. So, but what we say that in chronic ill patients or patients with advanced diseases, there's a limitation to the thing that a hospital or nurse or a doctor can do. So you have to take up some responsibility for yourself. And the community also should take responsibility for the people who are dying or who are bedridden in this thing. So it is an effort to overcome that barrier. And it's a network of autonomous community initiatives supported by trained palliative care professionals. They are there, but they are supporting the community, not that they are taking the community along with them. And the community and volunteers are empowered to take leadership. That's something different. They are empowered to take the leadership. Not just to be there as supporting the professional, but they are empowered to take the leadership. And they are encouraged to find the solutions for the care of chronically ill patients in the community. So this was something started in year 2000, and this went on for a while, and then later what happened, I'll tell you. Before that, I'll say what these volunteers do in the community. One thing is that they support the service, or they are supporting, or they are owning the service. In most places, most NGOs, volunteers end up supporting the service. They don't own it. They don't have any leadership role in it. But here, they are the leaders, they are the people who are running it, and this gives them the freedom to prioritize based on the ground realities and need. Because each state, each village can have different needs. So some people village may have some other resource, like a good hospital, which is supporting them. Others may not have it. So based on the local needs and realities, they can plan the program. Or it can be a follower or reverse. So most places it's a follower, but in our model, it was the volunteers were the leaders. So they are not fillers. Many times when we have pre-assigned tasks for volunteers, they can come and do this task and go back. No other input. But here, they are the pillars. They are the people who are supporting the entire program. If they are taken out, it will collapse. But in other programs, where they are not so much dependent on volunteers, if they are not there, it can survive, still survive. We have enough manpower to go on even without volunteers. But these programs will collapse if the volunteers are moved out. Or whether it's part-time or a part of life. Most of the time when you say volunteering, it becomes part-time. Like, you cannot volunteer full-time. But there's a correction here, because when you live in the same place, same community, the same neighborhood, you are available for 24 hours a day. So if some crisis happens or some issue is there with the family, they immediately call the neighbor. Even in the middle of the night, they will call the volunteer who is next to them. So in a way, you will be volunteering your time 24 hours a day. And we have people who are employed elsewhere, like teachers or bank employees or students. They still find some time to support these people even in any time of the day. So this is one advantage when you work in your own neighborhood. It won't happen if you're working elsewhere. Like if you work in a city far from your place, you have to travel to a place and come back. And your volunteering happens only as the time you spend at the city, in the city or the institution. And another important thing is accountable to the community, or you are accountable to the funders. But here, they get most of the income from micro donations, small donations, like people keeping the small hundi in the household, then putting whatever they can. It may be small. At the end of the month, there may be only 20 rupees in it. But even then, the family feel that they are also contributing it. They also feel some kind of a pride in supporting a program which is in turn supporting them. Or getting support from the bus services. This was something unique about the place, the Nalambur, I told you that the clinic. Every bus entering the bus stand will donate 2 rupees a day to this place. There was around, I think, 100 buses entering that day, I mean, in the bus stand every day. So they get around 6,000 rupees. So maybe small amount, but when it's pulled from different sources, it's enough for them to run the program without any external support. And that gives them the freedom to prioritize. I don't have to listen to somebody else who say that this is the way to do it. I do it based on what I understand about my neighborhood, what they need, and what I can do. And it's also a real-time quality control and this checks. Because if the service is not doing the job properly, it will dry up, the support will dry up. And it gives you you are answerable to the community, you are directly answerable to the community. And if something goes wrong, any financial mismanagement, they will immediately known to the people around. And another thing is that the presence of youngsters in the team. In the world over, when you say volunteer, especially in this kind of setup, you shouldn't look at people who are retired or have enough time or to come and spend time. But here, we have got active participation from the students. And of course, they help us in developing awareness programs or fundraising, etc. And last year, I don't know how many of you attended that. We had a 3-day carnival in Calicut, like a public awareness and income generation program. It's entirely run by the students. It was attended by almost, I think, more than 1 lakh of people. But all the plan, everything, execution and planning to execution, everything is done by the students of in the Calicut area. So this was possible with a lot of youngsters in the team, and it can be also tricky sometimes when you get youngsters. They are a vibrant group. But if you give them the bigger framework and the freedom to work within, then they can do a lot of things for your service. And another question comes up another issue we had some time back is that people always say that we train so many volunteers, and only very few actually come back and support us. But if you look at in Kerala, we probably have trained maybe 150 to 200,000 people over the last many years, and actually a fraction of them are involved in hands-on palliative care. The attrition rate is very high. Many people kind of left the. But what do we say that it doesn't matter. If the person is sensitized, he knows what palliative care is, and if you find a person who may benefit from palliative care, he'll be able to guide them. Or he may help with donations or other support programs. And we also feel that, I feel that the engaged active volunteers may be the tip of an iceberg. If they have a large number of sensitized volunteers in the community, more people will come up. So you keep on engaging, keep on sensitizing these people, keep on sensitizing the community. That's the only way to survive and to have new volunteers coming to your team. And the other is direct patient care or any care that will help the patient. Often when you say volunteers, they have given the task, like, okay, do this thing, or help the patient move, or support the patient, go to the toilet, or read him a story, or do some help for the patient. That's one thing. People who are able to do that can do that, but many people may not be comfortable with this kind of task, but they can help with something else. And we say that it's everybody's business. It's not just the volunteer or a patient or a doctor or a nurse has to do something about palliative. We say that palliative care is everybody's business. You also have a selfish interest here. Somebody yesterday mentioned that that we should encourage the people to develop program for a selfish motive, for ourselves. We are talking about palliative care, and I say that I'm happy to be in Calicut because it is well supported. It is supported 24 hours a day. But then it took almost 30 years to develop that kind of service within my city. And if you want that service to persist over the next 30 years, so till the time a time comes when I would need this kind of service, I have to heavily invest on my next generation. So it's our own selfish motive should be there, and we should be able to help people understand what it is and to develop this program. And this is what we have been doing this a lot for maybe 20 years now, 17 years now. And this is in summary, what the steps would be like in engaging the community. Basically, you start talking to a community, sensitize them, then we invite people who want to volunteer, train them, separately, like, in more ways, like basics of communication or what is issue, identifying issues of patient, doing the basic assessment, etc. Then what happens that sometimes they start working from that point onwards, even without any other support team, like they are sensitized, they know what to do, they start working with the patient. And if there's an issue, they will promptly take the patient to hospital or to a service which is supporting them. Or if they are resourceful enough, they can get the service of a nurse. So the quality of care will be even more better. And if they are well settled and they have more resources, they can hire a doctor or even develop inpatient, outpatient care services, depending on the source. But what we say that then the sixth step is that repeat 1 and 2, because that's the only way to survive. You have to sensitize, continue to engage the community, continue to do the sensitization program, bring in more volunteers. That's the only way to survive. So the step 6 will ensure that the program will go on. And basically there are 4 components: medical, nursing, sensitized or trained volunteers. And you can start with anything. You don't have to wait for all the pieces to come into place, then fall into places. And you can start with whatever skill you have, whatever resources you have, because if you look at the people on the other side, they have nothing. So you can start from any point, and from there you can move on. So this is what's happening with the community, the neighborhood network concept. And I will show you what happened to the service development within our state. So in '93, we had only one program, small program in the community, in the Calicut Medical College, where it started. Then in 2000, we had this concept of neighborhood network programs, in palliative care. And you can see the number of centers are still less, maybe around 50. And then in 2008 came the palliative care policy of the government of Kerala. By then there were around 200 plus centers who are delivering palliative care. All of them are in a community-based palliative care programs. So the political leadership at the time was very receptive, and they said that, okay, we'll have a policy. And what the government said that you prepare something and then we'll look at it. So this is the opportunity, and this all the 200 plus services, the NGOs, they came together, they drafted something, and they submitted to the government. And the emphasis on this program was home-based care. And that was surprising, because only, I think if the government is tasked with the task, with the task of creating the policy, they wouldn't have put home care as the first thing, as important thing, because it is totally out of the expertise, or out of the system cannot do this, because system is not tuned to do home care service. But since the NGOs were able to draft this, they said that this is what we want. And the government accepted the entire policy without much change. So in 2000, we had a policy, governmental policy, where they identified palliative care as a component of primary health care, and they said home care, based care is a very important thing, and it's the cornerstone of palliative care. Then the government machinery to work in harmony with the community-based organization, because at that time, entire resources and skills remained with the NGOs, not with the government. Government didn't have any skill or resources, only the policy was there. So they said that we need NGOs to work with us. So it was a collaborative program where NGOs helped the government to develop the program. Then government went further ahead and said, and created legislation to allow the local self-government to start palliative care program. Local self-governments, I mean panchayat, municipalities, and corporations. So Kerala had I think some of the states also have the decentralized administration program. So many of the administrative tasks are given away to the panchayat and the local self-governments. And health is one of the components that is given away to the panchayat. And panchayat has money and the freedom to decide what to do with the program. So the government made it mandatory. Initially they said that you should do it, and later they made it as a mandatory program. Like a midday meal program, this is mandatory that every panchayat should have a program to support bedridden people. And from there the change started happening. And I think in a way this is also important for the NGOs, because what happened with most NGOs is they are too comfortable with what they are doing. It's a nice service, and you get a lot of support and accolades, and people pat on your back and saying that you're doing something good. But then you remain within the region, remain within the program. So as pioneers, you should have the responsibility to move beyond that and make sure that the health system is also involved. Or you should not let the government go off the hook. Because if the government is saying they are going to do the work and then continue with it, that means that government is not ready to step into this. So, and NGOs cannot replace governments. You work in a small area. If every patient in the region or in the state or in the country has to get palliative care support, only government systems can do that. Because we have primary health center everywhere. NGOs are not everywhere. So you should empower the government, you should bring the government, make the government answerable and help to develop palliative care in the state. And that's what these NGOs did. And what happened that after that, all the 200 NGOs become one among the 1,000 programs. Suddenly, there are palliative care programs everywhere because we have 1,000 plus LSGIs and every panchayat started having a basic program. It's not something big. There's a nurse going out four times a week, seeing the patient who are bedridden, doing the basic care, coming back and reporting to the medical officer at the primary health center. And he will, based on his knowledge and understanding, he will support these people. So it was implemented through the medical institution owned by the local self-government. That way I say that when you decentralize administration means that all the primary health care trusts were transferred to the panchayat. So panchayats now had to look after this. It's not the centralized program anymore. So local people were deciding what's good for them and the local administration, local panchayat, helping to develop a program for people who are bedridden in that area. So you can see that 2008 onwards, there was a sudden rise in number of services in the state. And now what's happening that in 2019, we have programs in all 1,034 LSGAs. They have primary palliative care programs implemented through the medical institutions and the medical officers. And apparently what was happening is that all the medical professionals also getting trained. It's not just the services are being developed. Parallelly, the government has taken steps and supported, given enough funds to train the medical officers, nurses, and other people, staff in the health system. So they all know what palliative care is and they are supporting. So it's not just developing the centers alone. Then now the municipalities and block panchayats are supporting secondary programs in both CHCs and major hospitals. And all the 14 districts now have training centers. They run different training, sometimes they run awareness program for the public. And some districts, they run training program for nurses and doctors. So it's everywhere in Kerala. All the 14 districts have training programs. And now what's happening in this year is that they are revising the policy. I was part of the team who done the desktop review of the thing. And they are coming, they will be, I think it was expected this week, maybe this week or next week, they will come out with the new policy. And one important thing about new policy is that now they try to bring all the supportive care. Different programs are on, like that there is something for elderly people, there's something for mentally ill people, there's something for. So all these programs will be brought on one umbrella. And there'll be a lot of stress on secondary and tertiary care. Because primary care is almost kind of well secured now, but there's a lot of deficiency in the upper levels. Like if you need a specialist care, government system is not able to handle. So the policy focuses on the secondary and tertiary care programs that will be coming up now. And if you look at the some statistics, I've just priced it from a few documents. Now in any given time, this is now like last month or this month or month before that, approximately 1.5 lakhs people are supported by the network. Out of, we have around 1.3 is our population, and if you look by the 0.4% number of people needing palliative care will come around 1.5 and 2 lakh people needing palliative care. That means it's almost 80% coverage for the people who need palliative care. And every month, the primary programs does 16,741 home care. So each home care day, they may be visiting 5 to 8 people. So, but these are the number of home care days for every month. And we still have the NGOs, civil society organizations, they are still there. They are not redundant. They are still there. And they have, many of the organizations have moved to other areas, like they are continuing palliative care, but now they have the freedom to move on to other areas, like supporting the family, or developing other social programs, or income generation program for which the government is not able to do now. So they have moved on to other areas to support the patient. And many of the civil society organizations will also have more expertise in dealing with the patients who have severe symptoms. Like most of them will have doctors, and many of these centers will also have access to opioid. And they are, right now, looking after the secondary and tertiary needs of these people. Another important thing, the school campus program. 149 schools have programs, awareness, as well as in a campaign. They do basic awareness and the campaigns and fundraising, other things, and they have these programs, school palliative care programs. And if you look at the funding, and another thing is that the private hospitals, suddenly they also started showing interest in the program. Initially, they were kind of ambivalent about it, because these people are, anyway, incurable, they don't have much role, so they are immediately kind of sent back home. So nowadays, many private hospitals also run home care programs. Of course, they charge for it, but people are showing interest in it. This, I think, that's something tells you that the value of the program, because it's something important to people, and people are ready to pay if required. And then there are programs, hospitals who want to get it. And if you get the funding in millions, the panchayats together, I just took an average here, like I think that an average a panchayat would spend something like 5 lakhs in a year. We have 1,000 plus panchayats, and they will be spending 510 million in a year. Something like the NRHM, the NHM National Health Mission Program, they have contributed. They are mainly looking after secondary and tertiary program. They contributed 140 million. Government Health Services, 20 million. And the civil society organizations, NGOs, I don't know exact figure, looking at the 10 lakhs or more. Like we have institutions like IPM, whose budget is around 2 crores in a year, but smaller organization may not do that much. On average, they'll be spending around 300 million rupees for palliative care. So this is the scenario now in 2019. And if you look at the factors contributing the success in Kerala model, it's a concoction of many things. And one thing is that improved awareness among general public. It's effort by civil society organization, regular support by the media, sensitization program by the health department. And I would like to add that it's not just happening in de novo, because a couple of things which have contributed to this is one, literacy, the high literacy rate, and even high literacy, female literacy rate. That's also important, and we have more women in Kerala than men. So that's also contributed. And the support by media is something commendable, because they always look for stories. They also, anything happening in palliative care is a news for them. Like, so they come to all these meetings, they report all the meetings properly. And even one of the dailies, Malayalam Manorama, in 2006, they run a campaign for 3 months. They do that. Every year they do a campaign on certain social issues. So that year it was palliative care. So 3 months, every day there will be a small article on the front page, and somebody will be writing a detailed opinion on the page number 4 or editorial page, and there will be other stories in palliative care. So it ran for 3 months for the entire state. So that kind of commitment we get from the media. And so this has helped a lot in developing this program. Then high-level policy recognition. The awareness at the political level, that's very key. And the politicians were able to identify palliative care as a priority area for them. And this is very important, because generally doctors and professionals, we are very uncomfortable dealing with politicians. I've heard people saying that I wouldn't touch a politician with the longest pole available right now. But if you want to bring change in a big way, there's no other way but you have to engage politicians. You probably remember the saying of Rudolf Virchow, that the father of modern pathology. He said that medicine, the politics is nothing but medicine in a large scale. Medicine in a large scale is politics. But he was saying that I can find a solution for a certain condition, but if that need to be applied to other people, thousands of people, then it's not my duty, I cannot do it. But the politician has to do it. So you should learn to engage politicians in a constructive way, and that's the only way we can upscale our service. Otherwise, it will remain as a small program. And I think we have 140 MLAs. Yeah, 140 MLAs in the assembly. I think more than 50% of them will be able to talk about palliative care, and many of them has used the things that they have done for palliative care during the campaign. So there's a high level of political awareness on what's, and another thing is that, we have not totally lost the habit of asking uncomfortable questions to the politician. That's one thing about Kerala. We still ask questions, and sometimes we ask uncomfortable questions, unlike many other places. We still have not the habit. So people, they respond. They respond and they feel answerable to these the people. Then another important is state funding. So there's a state ownership. When they fund means they say they own the program. So there's NHM, Ministry of Health, and I showed the figures earlier. Other things are the National Health Mission. Once that NGOs empowered the government, encouraged the government to take it up, they use this, the National Health Mission. They come from the opportunity. Initially in 2009, they implemented this as an innovative project. It was not a regular feature of NHM, because they said that NHM is supposed to do something else, like maternal thing. And so they agreed to do a pilot in 2 states, 2 districts, and the results encouraged the government to scale it up into all the districts. So from 2009 onwards, NHM is the key player in palliative care. And NHM also able to get the support from the NGOs. If the training programs required, they look who has a training program nearby and then refer the patient to that, the professional to that program. So all the NGOs' resources and skills were used to develop the program. And they had the working, the broad vision of, to reach out to all the people who need palliative care in the state. And this is another thing which contributed, I explained it earlier, decentralized system of governance in Kerala. I think eventually it has to happen in all the state. If the Panchayati Raj, envisages that many of the administrative, I think there are 28 of them, need to be given away to the local governments, including health. So Kerala, and I think Karnataka has done, I think it's done almost, I think some 10 or 15 tasks already been given away. That means power at the local level, and the local people, local panchayat can prioritize what's good for them, and there's an accountability, direct accountability. You are not asking the state government what's happening, but you are asking your local ward councillor or local panchayat head of what's happening, or why it's not happening. So it's a accountability at the law. So, and another thing is that, important thing is that the home care with nurses as the lead. This is something innovative. Because all the time people were going to the hospital to get support, and people who are dying or lying at home did not have any support. So this was changed by having a group, nurse-led programs who actually went to the patient homes. It was a game changer, big game changer. And nurses are utilized as healthcare professionals better way, because they have a lot of skills, but in India, traditionally, they are set upon by doctors. So they just do whatever we say. Give that medication or don't give that medication, discharge the patient, don't discharge the patient. But here, they are asked to take the lead the program. So they are empowered, they're encouraged. Initially, we had difficulty. People refused to kind of go out on alone to home care service. But we initially went with them, and they gained the confidence, and then they start leading the program. So shifting care from institutions to patient homes was a big thing, and so that was happening in the state of Kerala, how it is evolved. Starting with an NGO, and then the NGOs were able to empower the government to take up the program. Then government did a good job, and there was a high level of political support and even state funding for this program. And coming to this, the theme of this meeting, in the community, we consider this as a taboo. We don't discuss that open. Like, even when there are instances when I took my children to a place, to a house where somebody has died, people ask, why you brought children along? I said, children should not come to these places, kind of thing. So that is where, because that we consider this as a disease, that's the dying as a disease. And I think only health institutions and professionals has to blame for it, because we lack the skills. As doctors, or nurses, we are not trained in looking after people who are dying. We are trained to cure people. And when they are not going to get cured, then we don't know what to do next. The easiest thing will be to send them home or send them give the responsibility to somebody else. I was telling Rube yesterday, one experience we had, a few years ago, we gave a half-day palliative care training program for the Department of Medicine in my place. And at the end of the program, we were discussing what should be done next. And then one suggestion immediately came was that now onwards, we will send all the dying patients to palliative care. And this is one department where 3,000 people are dying annually. They should be able to handle their own patients. And so, but this concept is not there, and people feel inadequate when it comes to death and dying, the professionals that need to be addressed. Then the community also lacks the skills. So when people go to hospital to die, or death is considered as a disease, or it is kind of happening as a taboo subject, then community is slowly moving away from they have lost all the skills. Even I narrate a personal story. When my grandfather was sick, he was had multi-infarct dementia, he was bedridden, and my grandmother took care of him beautifully, even without a bed. So only last, I think, 15 days he had a small bed so coming, but she took care of him very beautifully. But after 10 years, when my grandmother was in bed, none of her children knew how to take care of her. Then palliative care had to come in and support her. So we are also losing the skill. We don't know how to take care of someone who is bedridden and someone who is dying at home. This skill has to be reinstated. And another important thing, yesterday, Kishore was saying that how he supported your mother-in-law, at home, and they brought her back, and they were able to support, because there was someone coming to the home and suggesting, giving them support and telling them what to do or what not to do. And they were able to manage that beautifully at home. So we need support coming to the homes to take care of these people. So this is what we need. There should be support at home. Then that won't be that difficult, because we are taking the patient home. Even now, we have an inpatient unit at the Institute of Palliative Medicine, and one of the indications for admission is terminal illness, so somebody is dying. And when I go for home visit, we ask them, what do you want to do? Do you want to continue here, or do you want to get admission? And many people will say that we'll continue, because we also have a 24 hours backup. So even at the middle of night, a nurse-led team would visit you if you are in a crisis. But many people who opt for admission, they are doing it not for the patient, but for themselves. They feel that we don't know what to do, and we will be lost, or we'll be upset, and we don't know what to do or what not to do. So they prefer an admission at the time. So if the support is there at homes, then they will be able to handle the things better. Then open discussion on death. Death cafes, like somebody mentioned that yesterday, discussing death in public, openly. We do that often with our volunteer team and public. But then something I found is that the doctors again have difficulty here. Because Suresh, my colleague, he offered to his batchmates in his WhatsApp group, said that we'll have a death cafe. And there were many raised hands, said that, okay, we all want to come. We will discuss that, and we want to know more about it. Then somebody said that that's good for us, because now once we know what it is, then we can have a better conversation with our patients. Then Suresh said that it is not about patients' death, it is about your death we are going to discuss. Then everybody dispersed, and only 5 people or 6 people turned up on the Sunday. So even we are not accustomed to discussing our own death, or we don't know how to do it. So that's very important. Then advanced health directives, this is important. Because we need a reason to discuss death, right? And you cannot just go there and ask people, would you want to discuss death, or how do you like to go about it? But this is an opportunity. Advanced health directive, medical directives, gives us an opportunity and the patient to start discussing the death and understanding the death. So I think once it is there, we should popularize this. And every patient, I think everybody should be able to do it at some point of the time. And that gives them an opportunity to discuss death. And I think that, I don't know what, in any given format, there is one format, but I also know that ICMR has submitted a document to the Ministry of Health, and they might come out with it very soon. But once it is there, I think we should popularize it to all the media as possible and everything. And even last time Rube came to Calicut, he gave a presentation on advanced care directives. And one of the newspaper editors is after me after that. He said, I want more information on this. When can we go public about this? So people are interested. Even some of the volunteers are interested. They want to do it themselves. So this is one way of encouraging people to talk about on death. Yeah, that's it, and then these are some of the references. And thank you.
Thanks, Stan, you're on. Right, so I hand over to Dr. Stanley Macaden to organize the discussion for this panel discussion.
Just to remind that lunch is at 2 o'clock, okay, not 1:30. So we have half an hour of discussion now. And this last session has been rightly labeled, putting it all together. And I can say that I am probably the senior most active physician, palliative care physician in the country. And yes, I checked with Dr. Rajgopal. He's post-independence. I am pre-independence. And so it is very important for me that everything is put together finally before my eyes close. You know, I think we've been talking about this for years. Why aren't we moving ahead? Why isn't there an exponential increase in this kind of care, which is so fundamental? And so just touching upon a few points which were given by our great speakers, I liked what Dr. Yogesh said about the epidemiological transition, population as person. And that's what palliative care is. You matter because you are you. You know, it's bringing down that quality to that individual. Yes, we need coverage, we need, a lot of people to benefit, but we also need that quality that person needs in those final moments. Dr. Sanjay, about the conflict of interest and the catastrophic expenses. I think World Bank says nearly 60 million people are pushed into abject poverty in India because of catastrophic healthcare expenses. And most of it is in the last few weeks or days of life. So yes, we are trying to deal with two diseases. On the one side, the biggest disease is not death or any other illness. It is loneliness. The person on a ventilator, can you imagine the loneliness? Also, somebody in the abject poverty in the rural area where everybody has to go to work. He's alone suffering. But suffering can be very, very lonely thing. The other side of the disease is greed. And the only thing that can, bridge this is not medical legal paradigm or our professional paradigm. And I am sorry I missed yesterday's program, but it's the human paradigm. And unless we hang on to that, we will never win. And Dr. Anil, thank you for really explaining the Kerala model and emphasizing on the community sensitization, the catching people young, the students' awareness and involvement, and also the nurse-led program. And finally, Dr. Sanjay, I think, mentioned about the God syndrome. I think nobody can achieve the success that a palliative care physician can. We can get 100% success. All our patients die. So nobody can beat us. So my suggestion is that every specialist, every healthcare worker should be, practicing basic palliative care. Okay, so I now leave the floor open for questions. Yes.
Yeah, hi. So Dr. Sanjay was mentioning that, most of the work in the palliative, area comes from driven individuals or groups. And there's very little policy change as such. When it comes to policy change, usually like we've seen a lot of advances with like HIV patients and LGBT groups and those kind of groups where the people who are the perceived victims like form groups and advocate for themselves. But when it comes to palliative care, it's like an unfortunate situation where the patients cannot represent themselves in the public to advocate for themselves. So I was wondering, like in all the discussions that were happening, the idea of support groups, which is very, very prevalent in outside India, is like very lacking, in this Indian setup as such, because I think support groups can be a good ground to facilitate this kind of advocacy, like where patients share. Like one of the other problems we were talking about, even in the spiritual angst, was that why am I suffering? But if it's a support group where people come together and see that each other, there are people who are similarly suffering, that can kind of alleviate the pain. And I feel that the support group is a very vital medium to promote advocacy, because like that God syndrome, which Dr. Sanjay was mentioning, I think is very prevalent with the more able the physician or the surgeon, the more inaccessible that person becomes. Like from my personal story, like when I had an ileostomy reversal, there was nobody advising me on what to expect, because it was literally hell after that, with the unpredictable bowel movements and stuff. So
thank you for your suggestion. Yeah. Sanjay, you want to respond to that?
So, if one of the questions is the difference between the HIV movement, the movement led by HIV positive patients, to use the correct term. I think the advocacy and the fight put up by them, first of all, was much sharper, but also it was a very rights-based fight. It was a very rights-based fight. Of course, it had a lot of purchase, media, global attention. But it was fought with a rights-based fashion and directly. It was quite confrontational. I think the issue is, need, first of all, this is not that kind of confrontation. There it was about access to drugs, access to medicines, cost of medicines. So sharp, tangible rights that they were asking for. And I think here you depend much more on the medical profession, the health system to change its approach. That fight was could be fought outside of the system. And I think the TB survivor group now is putting up a huge fight on the FDR drugs. So that's the kind of sharp fight.
Yeah, I thank. It's on. Yeah, I thank all the three panelists for very interesting talks. I had a question to Dr. Anil. You portrayed so beautifully about how the community has come together. The government has been so supportive. So Kerala is not God's own country for its sceneries, but I think it's God's own country for the kind of public movement that you've had. My question is that when you say community, could you describe what is the nature of a community? Because I belong to a community of doctors, I belong to a community of my apartment mates, I belong to a community of medical graduates. So when you say community, like what is composing a community there? And
okay. When I say community, I mean the people around you. It can be your village, it can be just a neighborhood. Who is there around you and who can be the potential support for you when you have an illness or a sickness? That's the community. So, most of them are how large? Depends. Like in an average, a Gram Panchayat is trying to be something like 10,000 people, but not all of them need not be a community.
Yeah, so in my
Now what's happening that in the latest the government policy, they are looking at the ward level, they are trying to develop a system where each ward will have a nurse. And a nurse plus the volunteers from the ward. We are not even talking about the entire village. We are talking about your immediate neighborhood, who will be sensitized and who will be supporting the patient.
Yeah.
And that's in a way that helps, because even if the patient is not there, they can go ahead and support somebody else.
Yeah.
So in a way, that skill and that knowledge will remain within the community. That's what we are.
Yeah, I was just thinking about the same thing, because I have worked in a rural area and in an urban area. In a rural area, it's actually very easy to get the community together. In a city, it's extremely difficult. Most people are struggling with a sick family member. Even the neighbor doesn't know about it, or there's a lot of social isolation in a city actually. My next question is are you able to...
Just a comment on that. Okay.
Yeah.
In the big cities, we have an issue. But if you look at Kerala from north to south, it's more like a big city.
Yeah.
You cannot even have a 1 kilometer road without people or houses on either side. So that's we also found this, in the big cities, the understanding of your neighborhood is less compared to the villages. But if you make a real effort, then people do have to come up with help.
Yeah. My second question is, are you able to look at quality of care? Because you're talking of, very non-formal, non-medical engagement of the community initially, and then they're bringing in a medical component. So are you able to look at the technical quality of care? Because that also matters in symptom management and the quality of symptom betterment.
There have been, I think, one study to look at the process of the program, how it is implemented, I think done by the government a couple of years ago. And later, we're looking at the quality of the program. That is one concern that we have. Now, when we develop programs like that, we have the numbers now. So we have to ensure that this should be standardized care, everybody should be having a decent or same quality of care. And before the second policy comes into force, this is what they're planning. Understand that there might be an agency looking into the current practices, the processes, and the impact on this. But we have done smaller studies, like individual clinics have done what the patient needs or what the patient wants, how much of needs are met. But they are all for themselves, they do it for themselves and to fine-tune the program. But in large scale, for entire program, it's not. I think that's like one. Dr. Brinda.
Just to respond to the support group that you were talking about, actually there is a national apex body of support groups of nearly 100 agencies who have come together. And why it was called Cancer Care India, because primarily when they started this, it was only for cancer. Now they have diversified and gone into all aspects of palliative care. And to be honest with you, palliation doesn't start like yesterday. I think we talked about it's not only end-of-life care from start to finish. So palliation technically has to start from the diagnostic phase onwards. So therefore, they have brought in a lot of changes, and I think some of them even sit, in various parliamentary debates to move the bill and so on. So there is an apex body, and they're housed in Delhi. Thank you, ma'am. Yeah.
Dr. Shiv there?
I have a small question. It's to Dr. Yogesh. It was about the verbal autopsy and the study that you presented from Gadchiroli. So, if I'm not wrong, there was about 25% of not known. So, how does this number of not known impact the causation by the others? So, when we say that stroke is the most common, when you've got 25% which is not known. So, if that 25% were to go to infectious diseases, then that would become
No, that's a very valid question. It's a very technical question. The not knowns vary across the world based on how much access the community has to medical care. So if you go to verbal autopsy studies around Delhi, the not known category is about 15%. If you come to places like Gadchiroli, it goes up high up to 23%. And there are ways of also assigning, sort of the not knowns into particular categories. So, but even given that, if you look at other places where transition has occurred, stroke occurs early. So even in itself, stroke 14%, irrespective of what the others are, is still high. And then we also have the actual numbers where we can calculate the mortality rate. So instead of looking at percentages, we calculate the mortality rate. So even mortality rate is also high.
So the other part is that stroke is much easier to recognize.
Yeah, absolutely,
And
absolutely.
The person stays alive for a longer time.
Absolutely, absolutely.
Whereas ischemic heart disease, I mean, you die of a sudden heart attack and you want the work in.
Absolutely, absolutely. So that's always a concern, but again, as I said,
That's why stroke has become the largest.
yeah, so globally stroke is the second leading cause of death, and globally 11% of deaths occur because of strokes. In our study we found 14%. The unexpected thing was it was way too high in terms of bleeding, and then we have a theoretical framework which explains that why that is happening. So probably you have stroke deaths occurring earlier. As you move into more sort of pressure and obese phenotype, then you will have strokes and ischemic heart.
I am Dr. Desai from Goa. I have a question for Dr. Yogesh. You said that when a male person dies, the family, when he is bedridden, after some days he is left alone. Is it same for another gender? Is there any gender discrimination? And secondly, what is your experience about their community behavior during the death? Because I feel that they are more advanced spiritually in these cases. So what is your experience?
The issues are like a lot of assumptions. So rural area, like a lot of your assumptions get shaken up. So one thing is, it's the kind of life that they live is essentially centered around whether this person is useful or not. So when we are working on an intervention to reduce stroke rates, we picked up a population above the age of 50, and people between the age of 30 and 50 were very upset that why are you going and saving these elder people? They are going to die, die anyway. So overall, the community accepts that above the age of 60 they are of no use, and it might sound rude, but it is. I think it is born out of the hard practicalities of life, and death is just accepted easily, more easily than what we accept. So that's the difference. I mean, if you go to tribal areas, then the acceptance of death is even more. So very easily deaths are accepted. Even preventable deaths are accepted very easily. And then when it comes to males versus females, it's about the same. What we found in this study is like more men were taken to hospital for death. So 15% men died in the hospital as against 5% women. So there also, you can see the gender difference.
Yes, can I have one? Something we have observed, and I think there was one paper from Vellore on this. Like they found that when it comes to hospice admission, there will be more females coming to the hospice than men.
Even in our hospital.
Yeah, because I think there was one study from Vellore. And one reason is that when men are sick and they are at home, there are women to look after them. But when then women are sick, they have no option but to take care of. So this is also we have seen.
A lot of times also what you're seeing is, a lot of, we have more widows. Men die early, women outlive them by about 2 to 3 years. So we also see in villages that the women is only by herself. Many times they are demented and they are at mercy of neighbors. Sometimes neighbors forget and then the woman doesn't get food. A lot of these hardships that we see among women.
Dr. Yogesh, I had a question for you. In your presentation, you mentioned this case of a man who just wanted to slowly fade away into death, like stop eating and just wanted death to come. And you said that in rural areas, there's a very common scenario like that. So in that case, do you think the model of Kerala, where the power and the awareness about palliative care is directly given to the family members and the neighbors, would such a scenario help in your case? And secondly, I just wanted to know, in the end you mentioned about a care worker who actually inspired you to move from the US to Gadchiroli. If you could just talk a little about that as well.
I think the second is a different talk entirely, so let's not go into that. So, because I'll come to the first question, so essentially, as I said, acceptance of giving away food is a very common practice, and I was completely surprised. It's very akin to what you see in Jainism, like Santhara, or just stopping everything. So I was very surprised, but I think that's a very natural practice, and it's also ingrained in a social context. So the social context, what you see in Kerala, and social context, what you see in Gadchiroli will be completely different. So I showed the model of epidemiological transition. If one would to go into social sciences, we could also see, there is something called a Maslow's ladder. So you could see along Maslow's ladder, the communities could be along various phases of Maslow's ladder. So your solution, one of the biggest thing in public health is your solutions have to be contextualized. So if we want to follow Kerala model, it may not be immediately successful in Maharashtra at all, because for them this is a very alien, this is a very foreign concept. Kerala, as we see it today, has a long history of education and social movement. So that in India, that's always a problem that you develop solution in one state, it may or may not work.
And one thing we have tried to do these things in other places like Kadalur and some other states, and also in Suresh has few projects in Thailand and Sri Lanka. So what we found common in all these projects, if you are able to reach the community, they will listen to you. Okay, to how far they can kind of incorporate this into their practice, they have to decide, but it can happen. But Kerala, we adopted a bottom-up approach. We first go to the community, talk to them, sensitize them, then they will start working on it. In some other places, for example, Pondicherry, we actually use the NGO, it's already on the ground. We do not go to the community directly. In West Bengal, when they did a small sample, actually the district administration helped to, because it was inaccessible otherwise for people because it was an alien concept, they won't listen to you. Or somewhere it is the governments which facilitate it. So it can have different models, but what we think that if you sensitize the community, engage them, then they will be able to help you to find answers to their own problems.
I have a small comment on this, if you'll permit. So a community, question was asked, what is a community? So a community, like you said, is people around you. So it should be the apartment complex where you live.
Yeah.
And so therefore, I mean, for Gadchiroli, it will mean that village. And so like that, and they're already very community based. So we have to encourage that participation. That's the comment, sorry.
We'll take 2 more questions only. Yeah.
So one thing again is in rural India, that the feeling of community is gradually sort of fading away. You again romanticize that rural India, everything is like a community. The movement, natural movement is towards urbanization, towards urban behavior. So we live in apartments, which sets you apart. And community is like ways you feeling in apartments, things being put apart. So we also need to understand the larger directions where people's behavior are changing.
Good afternoon, sir. I'm Dr. Anjanelu from Sparsha Space, Hyderabad. So we are practicing palliative care in Sparsha Space. So to reach more number of people, and the nurses practice is very much needed, as seen in Kerala model. And can a nurse open a clinic for palliative care? Can she preserve her medications of narcotic drugs with her? If can, how much she can? Then after that, can she, declare a death? If she declares, it's a technical thing or not? So how to manage that?
Okay, we can again talk with Dr. Anil. Okay. Yeah. Okay.
There are 3 issues. One is whether opioids are carried, and then whether nurse can declare a death. Opioids, yes, the new rule. Earlier there wasn't any clarity on this, whether the home care teams actually can carry opioids with them. But the new revised NDPS Act clearly says that home care teams can carry opioids, provided there's a prescription. A doctor's instruct that this much need to be carried and given to the patient. Then the team can carry it, give it to the patient, keep an account. If not given, then you have to come back and so that's possible. The new rules allows you to carry, but there should be clear documentation of what you're doing. Thinking about declaring death, I think it's a very confusing area, because in many states, you actually need the certificate of a doctor even to take you to the crematorium. They won't accept it otherwise. But if you look at the legality of it, it's not required. What we practice here, if the death is happening in hospital, you will get a death certificate. But if that's happening in the community, you have to go and report to the municipality or panchayat, whoever, and they will make an inquiry, and they will give you a certificate. So basically, they do this, and an official to the neighborhood, they will ask around a couple of important people around, or teachers or post office or somebody. Then they will give you, if they are reasonably assured that this is natural causes, then they will. So this way, nurses don't have to. Okay, our nurses can say that this is what's happening or this is it, but they don't have to declare or sign any document there. They can come back. If the doctor is in the team, definitely we will declare it and also note down in the case number. Otherwise, the community or the family will do the same thing as they would have done even if it happened without the presence of the nurse.
Okay, one last question there.
Yeah. My question is to Dr. ANIL PALERI. So many of us may have heard of the term time banking in the West. Recently, last week, I saw an article in Times Now that the Madhya Pradesh government, they're planning to implement such a thing in the state. Will such a concept be helpful to further programs in Kerala as well as other states? Time banking.
I'm not aware of any place.
Time banking. Volunteers time banking. Anybody volunteer, you know?
You mean volunteers or?
In the you get the benefit.
Okay. In a way that I was alluding that when you say that you want to develop a program, you do it for yourself. Maybe next month or next year or maybe after. So that's why it's an investment. But I'm not aware of anyone putting as time and recording in documents somewhere that I have put so much hours for palliative care. I'm not aware of. But generally, you help people to develop this program, help the community program, develop the program.
Okay. So, thank you all very much. One important thing that needs to be done is restoration of trust. Wherever you are, whatever your role in healthcare, go out and see how you can restore that trust in the healthcare system, the doctors, the health workers, everybody. Thank you.
Okay. So we come to the end of this workshop on death and dying. Whether we have negotiated the maze or we are still more confused, I don't know. But I must say that we've had some awesome presentation, awesome speakers who have all spoken from their heart. And I'd like to thank everybody. I'd like to thank, of course, the participants. Without you, this would have been I'm so happy to see an absolute full house. And of course, I'd like to thank my team at Karunashraya for having worked so much. In fact, Maria and Priya would every time come and say, "Sir, there's already 65 registrations, but you know the hall, should we stop?" I said, no, don't stop registration. So, Giorgio, Priya, Maria, not necessarily in that order, Sangeeta, the rest of the staff who have taken a lot of trouble, and Girish, our HR guy, who makes all the arrangements for the food. Sudarshan, of course, he told me, he said, "Sir, the other day he said that everything goes off fine, you don't bother to thank me, but you catch me when something goes wrong." That's human nature. So thank you, Sudarshan, okay, for hanging here around in front. So now we break for lunch, and many of you have expressed a wish to see Karunashraya, and our CEO Matthew and Priya are very happy. We will form 2 groups and take you around, but that will be after the lunch. Okay, so thank you for participating. Yes, Linda?
I need to speak on behalf of the participants that I think it was a very, very well laid out program. It was really an intellectual feast. I know a couple of months back when Dr. Simha talked to me about this conference, I was just asking him whether there would be some kind of a live, program that we could do on a virtual platform, because we could connect with so many people. So he said, we haven't thought about it, and I think it's very expensive. A week ago, he called me and he said, we are going live. And the first thought that crossed my head at that point was Bangalore traffic. So staying at home and looking at this live, I thought was the best thing to do. But being a people person, I decided to come here. I think I would have really missed out on this interaction, and it was really, really an intellectual feast. Thank you so much for putting together a beautiful program, and thanks to Karunashraya team. I think we need to say 3 cheers. Hip hip hooray! Hip hip hooray! Hip hip hooray! Thank you, Doctor.
Thanks. All right.